Good afternoon, everyone. My name is Jennifer Yost, and I am a faculty member at McMaster University and team member with Health Evidence. It's my pleasure today to welcome you to our webinar series with Health Evidence and the first of the webinar series with our Knowledge to Action grant focused on disseminating research evidence to public health professionals throughout Canada. So we today are going to be talking about a systematic review about the health-related effects of government tobacco control. So after today, just to let everybody know, the PowerPoint and audio recording will be made available. These resources will be available through our SlideShare and YouTube channels, and we will be posting the direct links to these shortly within the chat section of the webinar that you see on the right-hand side. Today, this is the evidence that we are going to review. It is a systematic review, and we're lucky to have both of the authors, Steve Hoffman and Charlie Tan, joining us today to present the evidence. And again, as I mentioned momentarily, we'll post the link directly to the summary statement for the systematic review from Health Evidence so that you can retrieve it. So we have a first polling question. We're just going to try and get a sense of where everybody is from today. So we'd like to know, what sector are you from? Are you a public health practitioner, an education, research, provincial, municipality, or a policy analyst or others? So likely you have difficulty seeing the results, but luckily I can, so we'll give everyone a few moments to respond. And it looks like we have the majority so far, public health practitioners. We have some people joining us from provincial, territorial, government, and ministry, a few policy analysts, some people in research. So this is really great. We have a really wide variety of people, probably maybe a little bit challenging for our presenters today, but I'm sure I have faith that they can really make this good for all of those who have joined us today. So just give us a second. We're just experiencing a little bit of a technical difficulty as we're trying to advance the slide here. So just give us a quick moment. I apologize. So just a few housekeeping items as we start today. So we're going to ask that you use the Q&A and chat to post comments and questions during the webinar. Just a reminder to send questions to all panelists, although I will see them privately as a host. We will be having a Q&A session at the end of this webinar, and we hope to have lots of time to take those. And what I will do is I will read the questions that you've posted to our presenters today. So please, you don't have to wait till the end of the webinar to post your questions. I'll keep them, a note of them, and we'll ask them and get to them at the end of the webinar. And for any connection issues, just remember to use a wired internet connection. And we do have a WebEx 24/7 helpline that we also will be posting that within the Q&A the chat shortly, sorry. So, and then just a reminder to listen to the audio through your speakers if you, hopefully everyone is connected, and you'll just want to go to communicate on the audio connection. So again, we have another polling question here, and we'd like to know how many of you are joining our session today. We're actually finding a lot of people are joining the session within groups of people. So is it just you, 2 to 3 of you, 4 to 5, or over 5 of you? It gives us a good sense of who's joining today. So the majority, actually, we have a lot of people that are joining within groups, which is really great. I'll just give everyone a few more moments to finish up. Great, thank you so much to everyone who's responded. So some just me and some within groups. So I'm going to close that for a few moments. It will just take us a few more seconds. I'm really sorry to everybody. We're just having As usual, some fun technical difficulties this morning, so I apologize. And then we'll move on to the next slide. Great, so I'd just like to take a moment to introduce our Health Evidence team. There are a lot of us here at Health Evidence that are helping to run the registry, but also to implement the Knowledge to Action grant, which many of you are participating in. So there's a lot of people that are involved, so thank you to all of them. So just moving on to health evidence. So there are some of you who may or may not be familiar with health evidence. Health evidence was launched in 2005. It's a comprehensive registry of reviews of effectiveness about public health and health promotion interventions. So we provide over 90,000 visitors per year access to over 4,300 systematic reviews. And we have links to full text, plain language summaries, and podcasts, all to meet the main goal of health evidence, which is, in addition to making evidence about the effectiveness of public health interventions available, to make it easier for public health professionals to use evidence in decision-making. So what we like to really summarize and say about health evidence is that it saves you time. We have actually critically appraised all of the systematic reviews that are within our registry. It's relevant and current evidence. It meets selection criteria to be relevant for public health. Transparent process of how we get our systematic reviews into the registry, as well as how we critically appraise them. And we have some supports for evidence-informed decision-making available. And our feedback has been that it is actually quite easy to use. So this is a model for evidence-informed decision-making, which some of you may or may have not seen. And it has 5 components within the model. And traditionally, we find that public health practitioners and really decision-makers in any aspect do a good job of considering evidence about 4 of the circles, but what we're not so good at and what's a bit challenging is incorporating or considering the circle related to research evidence. So as such, this Health Evidence webinar series, as well as our Knowledge to Action grant, is designed specifically to identify research evidence related to public health decisions. And this is the stages in the process of evidence-informed public health, and what you'll see is that actually the review that we're presenting today has really gone through and done some of the work for us already. They've defined, they've searched, they've done some appraisal and synthesis of the interventions within their review, and it will be up to us to think about adapting, implementing, and evaluating the implementation of that into practice. So we'd just like you to let us know if you've ever heard of the PICO-S acronym before. So we'll take a moment to see how people are applying, and we've fixed, thankfully, the technical difficulty, but at the current moment, I actually am unable to identify the answers. So we'll see if we can work on that in a moment. So thank you. We'll give everyone a few more moments to respond.
Why can't you see?
Thank you to everyone who's replied, and we'll continue to move on. So for those of you who may or may not have heard of the PICO-S acronym, the P stands for population or situation. The I is the intervention or exposure, the C is the comparison or the other group, and the O is the outcomes. And in a moment, when we work through the systematic review that our presenters are presenting today, I think you'll really see that this starts to come alive. And I can actually say that from the results from our previous question, that there's pretty much a split that about half of the group has heard of this acronym before and half have actually not. So we have one of our last polling questions before we really get started with the evidence today. So we have this one and one more, but we just like you to weigh in on how often you use systematic reviews to inform a program or service that you work in. And do you always use systematic reviews? Do you often use systematic reviews? Sometimes, never, or do you not know what a systematic review is, which is, of course, completely fine. And I think our presenters today will give us a really good overview of what is entailed in a systematic review. So we'll give everyone a few more minutes, and I think everyone has responded. As soon as those results pop up for me, I will be sure to let everybody know of them. So it is my very sincere pleasure to welcome Dr. Stephen Hoffman and Charlie Tan with us today to present their systematic review work. Dr. Hoffman is Director of Global Strategy Lab and Associate Professor of Law at the University of Ottawa. He also has courtesy appointments as an Associate Professor of Public and International Affairs at the University of Ottawa. He's an Associate Professor of Clinical Epidemiology and Biostatistics at McMaster University and an Adjunct Associate Faculty with McMaster Health Forum, as well as an Adjunct Associate Professor of Global Health and Population at Harvard University. And again, welcome to Charlie Tan, who's MD candidate in the DeGroote School of Medicine at McMaster University. So before we get started, we'd actually like you to weigh in, and we're going to see if we change your mind or if your mind stays the same regarding whether you think government tobacco control policies improve health outcomes of the general population. So we're going to get a sense of what you actually think of that now, and following the presentation by Dr. Hoffman and Charlie, we'll get a sense of where you're at there. So everyone is so kindly responding. Thank you very much for doing that. And we will hopefully see those questions, the results of that question pop up momentarily. And then I will be passing the webinar on to our presenters today. All right, just give me one moment. There we go. Let's see if we can see it. So still waiting for so there's the results. So most people actually strongly agree that government tobacco control policies improve health outcomes of the general population. So let's see if we are correct. So without further ado, it's my pleasure to turn the presentation over to our presenters today. So Charlie, I'm passing the baton over to you.
Great. Olivia, Jenny, this is Stephen Hoffman. First of all, thank you very much for this opportunity in order to present our work to everyone here. I'm really impressed with, I guess the technology hasn't been working fully, but with what I see, it's very impressive, and I see there's 66 people attending, some of whom in groups, so this really is quite an honor to present this work in this format, so thank you. So this webinar is going to be about an overview of systematic reviews that Charlie and I conducted over the past couple of years and published last year in BMC Public Health. Next slide. And so this is important because, trying to move it to the next. Oh, got it. Okay, I'm sorry about that. So I've now moved it. In terms of the importance of the review, I think everyone's probably joined this webinar because you agree that tobacco control is an important policy imperative, and that currently we face a global tobacco epidemic, which is affecting health worldwide. And everyone here probably knows the statistics, but let me just emphasize them, and they're on the slide. So nearly 1 billion smokers worldwide in 2012. We have every year 6 million people die from smoking. It's a leading cause of preventable death. And out of the 6 million people who die every year from tobacco, 10% or 600,000 annual deaths are due to secondhand smoke. So tobacco is really a critical global health issue in Canada and around the world. And so it makes sense as time passes to always continually take stock of what does the evidence-based say about what government can do in order to address this challenge. And so the particular timing of this overview of systematic reviews was really timed with the 10th anniversary of the control. Now, this framework convention, it's an international treaty that was introduced by the World Health Organization. It was first adopted in 2003 and came into force in 2005. And so 2015, which was last year, which just ended, was the 10th anniversary. And so in this treaty, which aims to reduce tobacco consumption and tobacco exposure worldwide, in that treaty it includes policies that it recommends all governments to adopt. And so those policies at the time were based on the best available evidence. And so after 10 years, when there's been a whole new range of studies that have been conducted, we thought it would be helpful for policymakers and public health practitioners to reassess the evidence, the huge evidence base that's now out there, and try to provide a starting point to think about what it all means. And so this treaty, currently it's binding on 180 countries worldwide, which encompasses well over 90% of the world's population. Now, just to give you a sense of the policies that are promoted as part of the Framework Convention on Tobacco Control, a summary of some of the key policies that the World Health Organization and its various partners, like the Bloomberg Foundations and others, have really been trying to focus on as part of their efforts. So, for example, one is monitoring tobacco use and prevention policies. Others are about protecting people from tobacco smoke. Third, it's about offering help to quit tobacco use, warning about the dangers of tobacco, enforcing bans on tobacco advertising and sponsorship, and finally, raise taxes on tobacco. And so these are the kinds of policies that the Framework Convention on Tobacco Control talks about, and which we try to assess what the state of the evidence would be. Now, as I mentioned, our goal here was really, and the rationale for the review was really to take stock of the global research evidence base about the health effects of government tobacco control policies. Now, when doing so, there's many ways that one could go about that. One could consult the leading experts. One could look to particular jurisdictions and find out what works there. The approach that we took was, in some respect, the broadest approach, which is that we aimed, I think quite ambitiously, to try to synthesize all the global evidence out there in a systematic way. Now, in doing that, it's to actually incorporate all evidence would be impossible. But what we wanted to do was take a systematic approach and make sure that what we did would be as objective as possible and as transparent as possible. Exactly how we identify the evidence and how we analyze that evidence in order to come to the conclusions that we did. And so ultimately our hope here is to provide policymakers and public health practitioners with an evidence-based resource to start deliberations and decision-making about priority setting on tobacco control. And there's a couple of key caveats which we'll come to at the end as well when we talk about the strengths and limitations of this overview of systematic reviews. But to emphasize up front is that our goal here is really just a starting point. This overview of systematic reviews by itself should not dictate public health policies directly. Instead, the very first thing is they need to be contextualized for any local context or national context, given we really tried to go for what the global evidence base says. But we do think it is perhaps the best starting point for deliberations about where countries should start or where countries should start to consider reforms to their existing policies. So with that, I'm going to pass it over. I'm sorry, one more slide from me, and then I'll pass it over to Charlie. This overview, we only include systematic reviews evaluating government tobacco control policies. And what that means is that the evidence that we drew upon, it had to have already been picked up in a review that had its own systematic search protocol and analysis plan. So what that means is, in a sense, you could think of this presentation as presenting on a systematic review of systematic reviews, which is really what allows us in the end to include over 1,000 studies in this effort. It's because we're building on the work of other systematic review authors who did a great job. And so the advantage of this is that we get a much broader range of evidence on which to draw. So that's a real strength. We can include and did include more studies than mostly ever appear in these kind of syntheses. But at the same time, the findings are not as precise and are not locally contextualized yet. So that's the big caveat. So I'll now pass it on to Charlie.
So putting the study into the PICO framework that Dr. Yost previously talked about, so the population of our study would be really any individual who smokes and or may be affected by smoking through secondhand smoke exposure. Our intervention would be any government tobacco control policy. Our control would either be comparisons with other types of non-governmental tobacco control interventions, such as clinical interventions, or no intervention at all. A lot of these studies just looked at single government tobacco control policies independently. And our outcomes included any measure related to tobacco use, secondhand smoke exposure, and primary health outcomes. So for tobacco use, we define this as including things like smoking prevalence, the quantity of cigarettes consumed by individuals, levels of smoking cessation and smoking initiation. Secondhand smoke exposure outcomes could either be self-reported or biomarker-validated measures of exposure, and the health outcomes would include things like hospital admissions and the incidence of various diseases or adverse medical events. So our literature search, we identify any relevant reviews primarily through electronic databases. So health evidence, we search this for research in public health and health promotion, and I'll attest that it is quite an easy database to use. Health systems evidence for research and health systems, RX for change for research and behavior change interventions, the Cochrane database of systematic reviews for research on healthcare and health policy, and the database of abstracts reviews of effects for research on healthcare and health services delivery. And our search for these databases were recent up to March 2014. We also scanned the references of other overviews of systematic reviews that we identified. We received monthly updates from various databases as well, Health Evidence, Health Systems Evidence, and the Quebec Public Health Research Network. These were recent up to August 2014. And lastly, we consulted 2 tobacco control experts who are known to be authors, and we consulted them to identify any reviews that were missed by our systematic searches. So for study selection, we first conducted titles and abstract screening to identify any reviews for inclusion, and then we confirmed inclusion using full text review. And we had 2 independent reviewers, and any conflicts were resolved to discussion. I just realized you need to change the slide, so there that is. And then for exclusion criteria, so these included reviews that did not follow a systematic methodology, other overviews of systematic reviews, but as I previously mentioned, we scanned the reviews of these other overviews to identify any studies we had missed. We also excluded reviews that focused on clinical interventions such as pharmacologic therapy and counseling services. We excluded any reviews that focused on multi-component programs that we either could not independently study or identify the effects of individual interventions, or if they only studied the multi-component program as a whole rather than any specific focus on individual interventions. And lastly, we excluded any studies that did not directly assess change in smokers or people affected by secondhand smoking, such as the recall of media campaigns and people's perceptions of smoking. We had no exclusions on the basis of language. So the following variables were extracted from the reviews we identified into a standardized summary table. So we extracted a number of studies included in that review, the year of their last search, as well as any key findings from the review. We also extracted the quality ratings that are given by their source databases, and I'll talk about this in the next slide. So in terms of assessing the risk of bias for these reviews, we took the quality ratings that are given by their source databases. So health evidence, hopefully I'm misrepresenting health evidence when I talk about their tool, but hopefully I'll do them justice. They have an independent quality assessment tool that's specific for public health systematic review literature. So the total score can range from 0 to 10, where 10 is the highest, and then based on these numeric scores, a quality rating is given. So a score of 8 to 10 is strong, 5 to 7 is moderate, and then 4 or less is weak. Health systems evidence and RX for change, on the other hand, they use the AMSTAR tool. This isn't specific for public health literature. It's just for any kind of systematic review or meta-analysis. This is based on 11 quality criteria, and similarly, a score of 9 to 11 for them is strong, 5 to 8 is moderate, and then 4 or less is weak. And lastly, for the Cochrane database and the database of abstracts of reviews of effects, neither of these have a quantitative quality assessment. The CDSR provides no quality assessment, while DARE has more of a descriptive quality assessment. So for any reviews that were only identified through these two databases, we independently perform quality assessment using the AMSTAR tool to provide a numeric quality rating. We had 2 assessors of quality for these articles, and any conflicts were resolved through discussion. So because we wanted to focus on the most recent and accurate evidence, and as Stephen just mentioned, the Framework Convention came into effect in 2005, and we want to focus on what had changed in the world of government tobacco control policy since then. So we focused our efforts on reviews that were strong and moderate in quality, as assessed by either the Health Evidence or AMSTAR tool, or that were published, that were published since the year 2000. So this is kind of the PRISMA flow chart of the process that our review took. So our initial literature search identified 612 reviews. Screen titles and abstracts then yielded 67 reviews that possibly met the inclusion criteria. Full text review was then conducted, and through this process we excluded 22 articles for various of the reasons that I had talked about previously. That then ended up with 45 articles from the literature search. We then identified further articles from our other sources. So we identified 4 articles from our monthly database updates up until August 2014. We identified 9 articles through our consultations with tobacco control experts. And then with peer review feedback, we conducted a targeted search and identified one more study. So in total, we had 59 studies that are included in the overview, and then we ended up prioritizing 38 of the articles that were strong or moderate in quality and published after 2000. And through this process, through these 59 reviews, we were able to summarize over 1,150 primary studies. So how we organized our findings, we used the Empower components that Stephen talked about a few slides ago as our organizing framework. We also added an additional FCTC provision that wasn't included in Empower. It's restricting sales to minors. This is actually Article 16 in the FCTC, but it's just not present in Empower. We did not find any reviews for the M in Empower, monitoring tobacco use and prevention policies. In terms of our outcomes, we grouped these into 7 categories: tobacco consumption, smoking prevalence, smoking cessation, smoking initiation, secondhand smoke exposure, medical conditions, and hospitalization rates. So moving on to our specific findings, protecting people from tobacco smoke. This primarily includes things like smoking bans and restrictions in various areas, such as public spaces, workplaces, or residences. We identified 12 reviews about this intervention. 3 were strong in quality, 8 were moderate, and 1 was rated moderate by health evidence and as strong by health systems evidence. So in terms of classifying this by outcome, we identified 8 reviews that were evaluating the effects of these bans and restrictions of smoking behavior, and 6 of them reported reduction in smoking prevalence and cigarette consumption, as well as increases in smoking cessation. Our next outcome, exposure to secondhand smoke, 3 reviews investigated this outcome and all reported a reduction in secondhand smoke exposure with smoke-free policies in various populations, both adults and children, and also across various settings such as workplaces and hospitality establishments. Similarly, we found 6 reviews on health outcomes, and all of these reported reductions in adverse medical events. So for example, we had 1 review looking at hospital admissions data in areas where a smoking ban or restriction had been implemented, and what were found were pretty significant or less than 1 relative risk, so reduced risk of hospital admissions for heart diseases, coronary events, cerebrovascular accidents such as strokes, and respiratory events with these smoke-free policies. And again, these reductions in adverse medical events were greatest in areas that had comprehensive policies banning smoking in various types of properties and establishments. So just based for this first intervention, we found very strong evidence that smoking bans and restrictions are able to reduce smoking behavior, exposure to secondhand smoke, as well as adverse health outcomes. So our next intervention, the O in Empower, is offering help to quit tobacco use. Interestingly, this can be targeted to different people in different ways. So this can either be financial assistance for smokers to reduce the cost of smoking cessation interventions. It can be incentives or competitions for smokers to kind of promote them or almost coerce them to quit smoking. And lastly, it can be provider-directed financial interventions or incentives for healthcare practitioners to provide smoking cessation interventions. So of these 12 reviews, 8 were strong in quality and 4 were moderate. So we found different effects depending on who these interventions are directed to and what they entailed. So we found 2 reviews that investigated smoker-directed financial assistance, and we found reduced smoking behavior in both of these reviews. However, for incentives and competitions, we found 8 reviews and the evidence was more mixed. So 4 reported beneficial effects on smoking behavior, while the other 4 reported either inconclusive or no effect. And then lastly, for provider-directed financial interventions, we found 3 reviews, and none of these reviews on incentives to healthcare practitioners found a beneficial effect on patient smoking behavior. So therefore, our conclusion for this intervention is that financial interventions may be most effective when they're targeted to smokers to make cessation therapies more affordable. Incentivizing quitting for smokers may also be effective as well, but there isn't much evidence suggesting that smoking behavior in patients can be changed by incentivizing healthcare professionals. Warning about the dangers of tobacco. This includes 2 types of interventions. One would be health warning labels or plain packaging of tobacco products. So we see that in Canada, at least, in all the tobacco products that we purchase. And the other types of interventions would be mass media campaigns to promote smoking cessation or preventing initiation. So we found 9 reviews about this intervention, 4 strong in quality and 5 were moderate. So for health warning labels to decrease smoking, we found 3 reviews about this intervention, and 2 of them reported beneficial effects on smoking behavior. We found 7 reviews on mass media campaigns, and 5 of these took place with the mass media campaign as part of larger multi-component tobacco control interventions, and 4 of these 5 reported beneficial effects on smoking behavior. An update to the lone reviews that did not find a beneficial effect out of the 5 that I had just mentioned, an update to this review was actually recently published, and they kind of went in line, and then they also found that mass media campaigns are able to improve smoking behavior in people. Furthermore, various components or aspects of campaigns, mass media campaigns that were associated with increased success were identified from these reviews. These included things like wide population reach, high intensity, a long duration that the campaign runs for, the use of television as well as the media, and messages on the negative health effects of smoking. So therefore, the evidence for this intervention suggests that interventions, either health warning labels or mass media campaigns, are both able to promote quitting or reducing smoking prevalence, and mass media campaigns seem to be very important parts of multi-component tobacco control programs. The next component of Empower is enforcing bans of tobacco advertising, promotion, and sponsorship. So basically bans and restrictions of tobacco advertising. So we found 4 reviews on this intervention. All of them were moderate in quality. And in terms of review evidence, we really didn't find much or any clear reduction in smoking behavior. What's interesting, though, is that the converse relationship showing that smoking advertisements have a significant effect on people's smoking behavior, there really is a lot of evidence on this relationship. So a lot of studies have demonstrated that tobacco advertising, featuring smoking in movies, in other types of media, are able to change people's attitudes and susceptibilities towards smoking, and this then places them at greater risk of starting cigarette use and then continuing this behavior onwards. So although our review evidence didn't find necessarily much evidence supporting this intervention, I think a strong case can be made that advertising can have a very significant effect on people's decisions to start smoking, continue smoking. We also found deeper into the evidence that there were individual studies that supported the effectiveness of these interventions, but one kind of caveat was that the success of these interventions seems to depend on how comprehensively they are enforced and also how comprehensive they are in terms of scope. So, for example, one study found that comprehensive advertising bans are quite effective, but limited advertising bans that still leave certain avenues of advertising and promotion open to cigarette companies. These are unable to reduce tobacco consumption. So in summary, although our review evidence didn't show any kind of strong evidence for enforcing bans on tobacco advertising and promotion, there is other types of evidence that demonstrate that this still seems to be an important intervention for tobacco control.
Hi, everyone. I'm very sorry. This is Jenny Yost at Health Evidence. We have temporarily lost communication with the webinar platform because of the computer issue. So I'm not sure if people are still able to hear us. Stephen and Charlie, I apologize. So we may just need to pause for a moment while we figure things out.
No problem. Let
Okay,
Charlie
so we've confirmed that it is actually only the computer which I'm sitting at, so please carry on. I apologize for that.
Yeah, no problem. So the next intervention, raising taxes on tobacco. So this is tobacco price increases. We found 6 reviews evaluating tobacco price increases. 1 was strong in quality and 5 were moderate. And this is another one of our interventions where we found a lot of strong review evidence. So 5 of the 6 reviews we found, they reported that increasing the price of tobacco reduces smoking behavior with reductions in cigarette consumption and smoking prevalence, as well as increasing smoking cessation. So an interesting metric that's used in these studies is the price elasticity of demand. So essentially, with a 10% or 20% increase in cigarette prices, what is the corresponding reduction in smoking behavior? So one study we found, or one review rather that we found that with a 10% increase in cigarette prices, there is a 3.7% reduction in smoking prevalence and a 2.3% reduction in cigarette consumption. And this is actually quite a large increase if you consider that a lot of countries that implemented these price increases, they increased the price of cigarettes by 30 to 50%. So correspondingly, you need to increase the reduction in smoking prevalence, cigarette consumption by 3 to 5% as well. So with just this price increase, you can expect maybe even a 10 to 20% reduction in smoking prevalence, which is quite significant. So our evidence suggests that increasing the price of tobacco products is a very important intervention for tobacco control. And the last intervention that we focused on, restricting sales to minors. Again, this wasn't part of Empower, but it is Article 16 in the FCTC. So we found 5 reviews about this intervention. All of them were moderate in quality, and across all of these reviews, there was very inconsistent evidence with regards to how they affected smoking behavior. 4 of the studies found inconclusive or unclear effects. One study did find that banning the sale of tobacco products to minors can be an effective strategy to reduce smoking and youth, but this is predicated on the restrictions being very strongly enforced by some sort of enforcement agency or body. So in summary, our evidence that we found on youth access interventions is inconclusive, and if these interventions are effective, they appear to depend very strongly on robust enforcement. And again, I didn't change the slide, my apologies. And I'll now be passing the baton back over to Stephen, who will conclude our section of the talk.
Great. Thanks, Charlie. So in terms of trying to distill everything that Charlie went through into some principal findings, what we've done here is present 4, and we've tried to group those tobacco control policies for which there's, basically in order of how much evidence there is showing that it's effective. So first, the strongest evidence is for smoking bans and price increases of tobacco products. So what this means is that if countries don't currently have any smoking bans and price or efforts to increase the price of tobacco, this is where those countries or jurisdictions should start their conversation, because they can feel very confident that there's a lot of global evidence to support having these kind of policies in place. Next, there's also quite a lot of evidence showing positive results from mass media campaigns that are part of multi-component programs, as well as cigarette packaging interventions. So if a jurisdiction doesn't have these or is looking to reform the way that they currently implement these kind of policies, this would be the next place to have a good conversation. Third, in terms of the evidence about financial assistance for reducing the cost of smoking cessation and financial incentives to quit, these may be effective strategies. There are individual studies showing that they work in some contexts. There's other studies that show that they sometimes don't work. And so that one is, there is evidence to support them. It's not as overwhelming as the other policies I just mentioned. And finally, as of right now, there's limited evidence in systematic reviews to demonstrate the benefits of advertising restrictions and youth access restrictions. So that doesn't mean that these aren't effective policies. It doesn't mean that they're not good. It just means that when you look globally across all contexts in which these have been studied, and when those studies have got into existing systematic reviews, overall the evidence doesn't show that they're globally always effective, although of course they might be very effective for particular purposes in particular contexts. Now that's a perfect segue to talk about and limitations. So the strengths is that this is a synthesis of a huge number of studies, over 1,150. The second is a systematic and transparent search protocol, which and all of the systematic reviews that we included also followed their own systematic and transparent search protocol in the individual primary studies. In this overview, we also prioritized our evidence synthesis according to its quality and most recentness in which it's been published. So as Charlie mentioned, we found quite a lot of systematic reviews, but the evidence, the conclusions that we have highlighted here, those were based on the strong and moderate quality systematic reviews that were published after 2000. Now, in terms of limitations, so the search did not include a search for unpublished reviews, submitted, for example, but not yet published. Those are just much more difficult to find and in many cases don't exist. Reviews in other disciplines also might not have been included. And by that I mean that there's certain different disciplines, for example, economics, which have a different culture around evidence synthesis. So my understanding from colleagues who are economists is that often in that discipline there isn't the same tradition of having a systematic search protocol and inclusion-exclusion criteria over what studies they include and don't include. And as a result, those would have been flagged in our review as low-quality reviews, mostly because they might not have been systematic. So that's there are disciplinary differences to think about here. Third is that by attempting to summarize so many studies, we lose the intricacy and context that each study provides. And fourth, given we were trying to provide evidence about different components of tobacco control policies, it meant that there were some reviews that were only looking at multi-component interventions, which we needed to exclude. In terms of future directions, so based on this overview, we would recommend that all jurisdictions begin any conversations either about new tobacco control initiatives or existing ones, about reforming existing ones, about smoke-free policies and efforts to increase the price of tobacco, given that the evidence is so clear that those policies work. Now, what we do, though, recommend is further studies of the remaining interventions in order to better understand what context in which they might be most effective, whether they're effective for different populations, or various factors that might influence whether policies work. So, for example, cost, local context, whether there's political barriers that need to be overcome, or implementation strategies that can be used in conjunction with policies to make sure they work. And then one thing which we didn't do in this overview, and which we hope future researchers do, is looking at the possibility for synergistic effects of multi-component programs. This is based on the fact that if we do maybe 2 interventions, maybe 1 + 1 equals more than 2. And if that's the case, we will need further studies in order to figure out how we actually do that. And of course, we think that there needs to be further research about what kind of end game proposals there to actually totally eliminate tobacco use, or at least work towards that goal. And so finally, the overall summary and implications are that countries should ideally implement these policies and have serious conversations about maybe reforming existing policies that they have. It was the 10th anniversary of control. I think it's a good time to revisit what countries and other jurisdictions are doing in order to see whether they can be done better. Certainly, we propose in this overview some starting points for that conversation, but the Framework Convention on Tobacco Control overall provides other starting points as well, and a continuation, or at least other ways to continue that conversation. So thank you very much, and I look forward to the question and answer period. Thank you.
Great, thank you so much to both of you for a wonderful presentation. We do have another polling question here for you. So we're wondering, same question as before our presenters started, do government control policies improve health outcomes of the general population? So before we started today, most people agreed or strongly agreed, so we're going to try and get a sense of what people think now after the presentation. So we continue to have our participants on the line say they strongly agree. There are now a few neutrals as well, so it's really great, and people are continuing to respond, so thank you very much. And then we'd really like to know, or quite interested, is do you agree with the findings of this review? And the polling question will likely be released momentarily, just waiting for the other polling question to close. But do you strongly agree with the findings, agree, neutral, disagree, or strongly disagree with the findings of this review? So as people are responding, most people strongly agree or agree, a few neutrals, but mostly people, for the majority, do agree with the findings of this review. So thank you to all of you who are providing your responses today. So we would like to take some time, and we have plenty of time this afternoon, to pose questions of our presenters. And thank you to those of you who have already sent some questions through. So we will go ahead and start with those. Stephen and Charlie, their questions aren't particularly posed to either one of you at the current moment. So the 2 questions that we currently have, I will just pose aloud and let one of you decide who's going to take on the question, if that's okay with the both of you. And again, I would just encourage you to post your question in the Q&A if you have some questions for the presenters. So we do have a question from Michael, and his question was, is there any objective evidence that tobacco price increases by higher taxes have a negative side effect, such as increased contraband? And he followed up with that saying, in regards to this question, while he's particularly interested in the tax question, it's always important that we be able to qualify tobacco control evidence with a no negative side effects statement.
So I guess I can just speak briefly about the evidence. So I didn't come across anything that explicitly kind of showed any empirical evidence about the consequences of increasing the price of tobacco products, but one thing that was noted in the kind of global progress reports that the WHO releases every few years about the FCTC and how it is being implemented is that although raising tobacco prices is really a critical government tobacco control intervention, there, as you mentioned, of course, there are kind of externalities from that or unexpected consequences. So one thing that's been noted is that although you expect that if you increase the price of tobacco products, people are going to purchase tobacco products less in favor of maybe daily necessities such as food or shelter, et cetera. But what happens in certain populations, in certain cultures, is that people actually forego those other necessities or daily goods in favor of cigarettes. So definitely something that you have to think about in terms of increasing the price of tobacco products. And also what comes along with increasing the price of tobacco products also should be potentially decreasing the price of cessation products as well. I think that may answer your question a little bit.
We will ask Michael if you could respond and let us know if we've answered your question. That would be wonderful. In the meantime, we have another question, and this question was sort of posted during the presentation, but I will still go ahead and pose it in case you do have a response. So Nero posted, wondering if the presenters will present results limited to only strong quality reviews. In particular, I'm wondering how many of the studies appropriately address the problems of endogeneity.
Yeah, so we did, in terms of the findings we today and that we prioritized in the we look to strong quality reviews. So what that means is that the systematic review methodology that was followed in the systematic review that was it was pretty transparent. It was very clear what kind of search they conducted. It was clear once they decided which individual studies would be included and not. Now, for those individual systematic reviews, there's different ways of coming up with criteria for inclusion and exclusion of studies. One of those criteria would have been, though, based on the study design to evaluate the effects of the policies. And so some of that is about trying to get at looking at whether there were controls for endogenous factors, as the question referred to. But for external factors that might influence the study results is very difficult. Now, I think that's a randomized control trial where we randomize countries and decide which countries get what kind of tobacco policies, but I don't think most prime ministers and presidents would follow how we allocate them in our randomized control trial. So instead, what we have to use is other types of studies where we try to control for whether we can see an effect or not of this policy. And so sometimes we use time before and after. Other times we might compare similar populations, let's say in a border town, comparing one jurisdiction has an intervention, the other doesn't. So yes, ultimately a lot of the systematic reviews that we did include would have studies that addressed endogeneity in different ways.
And just in terms of presenting results limited to the strong quality reviews, those are the ones that are prioritized in our presentation and the paper itself, but in the actual text of the paper, we do have an additional online web appendix where we summarize the results of all of the 59 reviews that we have identified through full text review.
Great, thank you to you both. And Michael has replied to his previous question regarding tax. Thanks, helpful answer, although we have a localized challenge in Ontario with pro-tobacco interests advocating price increases because they allegedly increase contraband levels. Understand that this local issue is beyond the scope of your review. And so we have another question that's come through, and Joelle has posted, considering the findings, it could be a wrong measure to change legal age to buy tobacco from 18 to 21.
So the findings, so we did, there is, in terms of looking at the systematic reviews, there's limited evidence that youth access restrictions have the positive effects that we would all like them to have. There is individual studies showing it in particular contexts. So before actually making a recommendation like that, I would probably want to see whether there's individual studies that assessed the impact of anything like this in the jurisdiction that's looking to make that change, or in a similar jurisdiction, because some of this might relate to culture or the existence of, or the youth access restrictions. So I wouldn't want to, I mean, we couldn't, based on this overview or based on any kind of overview, one couldn't make any very specific recommendations. But I guess what I would suggest is that based on this overview, is that if I was a public health practitioner or a policymaker trying to think about, okay, it's maybe time to reconsider how we try to reduce the use of tobacco in our jurisdiction, I wouldn't start the conversation with youth access restrictions. I would start the conversation with smoking bans and policies to try to increase the price of tobacco. Yeah.
And in terms of, the youth access restrictions that were summarized by the review literature, these are primarily more kind of at the vendor level, so communicating with vendors of cigarette products to prevent them from selling cigarettes to minors or to have greater enforcement in terms of checking their age. I think you can also make the argument that if at a national level to change the legal age to buy tobacco products to a higher age that has other kind of broader and more societal implications that might also have an added effect that aren't captured by studies on simple youth access restrictions at the vendor level.
Great, thank you to you both. And the questions just keep on coming. So thank you everyone for posting your questions, some really great questions and some really great responses from our presenters. So Jose was wondering, did you find any reviews that discuss the effectiveness of tobacco control and addressing social inequalities in smoking? In your opinion, how can tobacco control address this issue?
So I did actually find quite a few, or we actually, found quite a few reviews that looked at the social inequalities in smoking or how these interventions might affect people of different socioeconomic status or of different cultures, ethnicities, et cetera. And that wasn't a focus of our review, but just to give some examples, there have been some reviews looking at how certain types of messages are more effective in smokers who are pregnant, or certain types of interventions or health messages being more effective in certain Aboriginal populations. So there definitely is not only evidence about the different social inequalities affected by tobacco control policies and interventions, but also some evidence does seem to suggest that some of these interventions can be tailored for people of different cultures or socioeconomic statuses.
Great, thank you. And another question from Bill. Is there a significant variation in the results of the review between countries or populations studied? So the answer to that would be depend on which tobacco control policy we're talking about. And that's why Charlie and I grouped them in the way we did. So whereby it seemed like that the evidence was
monolithically in support of smoking bans and efforts to increase the price of tobacco use across jurisdictions and populations. That seems, when there were systematic reviews, seem to overall conclude that, sort of everywhere, or for the most part. Whereas it seemed the evidence was more mixed when it came to some of the other policies, such as financial assistance for reducing the cost of smoking cessation interventions or financial incentives to quit. So what that says to us is that I'm not sure if it differs by country, but it probably does differ very much by, or at least there's a chance that it differs by population, or it differs in the way that those interventions can be delivered, because of course there's so many different ways that these different policies can actually hit the ground. So we didn't, in our overview, we didn't actually analyze whether there's differences in countries. That's a really interesting question. But yeah, at least by population, we can say yes. And it would vary by the different tobacco control policies. Great question.
Great, thank you so much. So I'll give we'll just move along just a tiny bit in the slides, but please, great, we have another question. So Mark Andrew has asked, by limiting analysis to empower strategies, is it possible that other types of tobacco control policies might have been overlooked? For example, neutral packaging, regulating nicotine content, education.
So I can speak to this a little bit. So although we limited not limited, but kind of framed our results in terms of empower strategies, our actual initial search, we didn't go into it thinking about organizing our results by the empower strategies. Our search strategy is actually quite broad. So for health evidence, we searched tobacco use, and then for the other databases, we searched tobacco. So it was only after we got our results that we found that the empower strategies were a very good fit in order to organize the results. Had the review evidence being focused maybe on other interventions, we definitely would have included them as well, as we included the intervention restricting access to minors. We found some reviews about this, and although it wasn't part of empower, we still included it into our overview of reviews.
So just to emphasize, we didn't, in our systematic search for systematic reviews, we didn't find any systematic reviews on, for example, regulating.
Great, thank you. And thanks again for your questions, everyone. I'm just I'll advance the slide for a moment while we wait to see if there are more questions that come in for our presenters. And so would just like to bring us back to the model for evidence-informed decision-making. And again, really the whole emphasis of our webinar today is really to try and help those of us making decisions about these topic areas to really consider research evidence, or as you see the purple circle in the model. And I think that our presenters today have really given us some really good things to think about how we can incorporate the research evidence from the systematic review into decisions that we are making. So thank you. Just again, reminding people to please, if you have any further questions, you can post them in the Q&A section. And we would like to thank those of us who have joined us as part of our Knowledge to Action study, which is funded by the Canadian Institute of Health Research, supporting awareness and uptake of cancer prevention in knowledge and practice. So while we have some health evidence registered users, we also have some of our KTA participants. And this is also just a reminder that we are actually still recruiting for this study. So if you know of anyone who might be interested in participating in the study, to please go ahead and forward the information about our study. We will likely have recruitment continuing for the next month or so. So again, just looking to see, we've had some comments. Thank you for this event. So you're quite welcome. It's great to have such wonderful presenters joining us today. And we do have another question from Joelle, who's asked, about tobacco price, did you see some reviews about anything different than just raising taxes?
So I think in the reviews that we found, most of them were focused on increased tobacco price through taxation.
Great, thank you.
Yeah,
sorry, go ahead.
We didn't find any. Oh, I was just going to say that we didn't find that was the mechanism through which the systematic reviews that they was evaluating. Yeah.
Great, thanks. And again, thank you to the participants who are continuing to post questions. So Liz would like to know, was there any evidence of a hierarchy of interventions? For example, did the evidence for effectiveness of interventions vary depending on whether or not a jurisdiction/country had policies on restricting tobacco use in place?
So I'm just reading the question here. So if there's a hierarchy of evidence, vary depending on. So in terms of the hierarchy, there's, I mean, we didn't want to present a hierarchy in terms of what should actually do, because partly what we don't include in this overview of systematic reviews is any information about the cost effectiveness. So we don't include information about cost. So one thing that jurisdictions will definitely want to do when taking this overview is think about, okay, here are the different things. Before we think of our own hierarchy for our context, how much would it cost us to actually do different things? So tobacco taxes to increase the price of tobacco. Maybe, for example, in Canada, it's maybe easy to just increase the price of tobacco. It can actually be a money-raising move. But if they don't currently collect tobacco taxes, it can actually be enormously expensive to set up that kind of tax regime. So it's the costs then are so different, such that when we were trying to do an overview of the global evidence of effectiveness of these different policies, it was impossible to put them into a strict hierarchy of what different jurisdictions should actually pursue. So instead what we did is we put them into a bit of a loose hierarchy of policies that we think a jurisdiction should maybe start talking about. So at the top of our hierarchy for discussion would be the policies that ban smoking in different places and that increase the price.
Great, thank you so much. And just waiting to see if anyone has any further questions. Checking the chat and the QA. Move forward on the slide. And so while, again, we'll give people a few more moments for last-minute questions, but here at Health Evidence, we'd like to give you some thoughts about what you can do now. So you can visit our website, which is the repository for over 4,000 quality-rated systematic reviews, including the systematic review that was presented today. You can register through Health Evidence to receive free tailored message updates in our monthly newsletter, which will prompt you with evidence related to the areas in which you work, which is really a great way to stay on top of things and have it come through your inbox. You can tell your colleagues about Health Evidence, how it can help you and others to use good quality research evidence in practice. Health Evidence is also on Twitter, so you can feel free to follow us there. And similar to signing up for our monthly email tailored messages or newsletter, we actually tweet daily public health review related tweets. And also there will be more information about upcoming webinars and things that we are holding here at Health Evidence. And just encourage those in your organization or those you work with, that health evidence could be one of the first stops you might go to for evidence related to public health interventions and their effectiveness. And as always, we are very much open to suggested topics for future webinars, as well as any feedback that you have. So as we conclude, I would just like to take a moment to say on behalf of Health Evidence, thank you so much to the participants who have joined us and our presenters today. It's quite wonderful to have the experts in the content area to really present on their topics and provide some really key, great information and be able to ask some questions, so thank you. And I'll just turn it over to you, Stephen and Charlie. Do you have any last-minute words of wisdom that you would like to share with our participants before we close the webinar for today?
No, but thanks to Health Evidence team for organizing this and inviting us to do it, and for everyone for being there and participating. To do our overview of systematic reviews, we depended on Health Evidence. This tool, which, as Charlie mentioned, was easy to use, and we'd really recommend it to everybody. So not only, I guess, is this a webinar hosted by Health Evidence, but actually to do the work that we presented, we couldn't have done it without Health Evidence. So thank you. Thanks, everyone, for being there.
Yeah, thanks to Health Evidence and everybody.
Oh, sorry, Charlie, before you give the last word, we did have one more question come in, if you don't mind. So Bill has asked, there seems to be a tendency to use the principles of tobacco control to address other public health concerns, for example, obesity. What are the pros and cons of such an approach?
That's a great question. One I get asked quite a bit. I mean, I guess we should be learning from any success we've had in tackling one kind of health problem. We might as well learn from that problem to address other problems. The challenge with obesity is that it's a very different problem than tobacco. I mean, yes, we're trying to reduce consumption of particular things as one way of targeting obesity. But the differences are also quite stark in that we all, as much as we might not, we want to limit eating maybe particular kinds of food. We all need to eat food, whereas we don't need to smoke or chew tobacco. That's a big fundamental difference. It's also just different culture around the different products, such that a lot of, like, imagine having bans on eating in different public places. It just wouldn't work. I mean, certainly we can learn about some things. So, for example, successes of tobacco, at least the Framework Convention on Tobacco Control, was the principle that policies need to be made without the influence of tobacco industry. And so whether that's applicable or acceptable for food, I'm not sure. There's pros and cons of including food manufacturers, for example, at the table and making policy. So but we can learn from that experience. And at least in Canada, I see that many people on the webinar are participating from Canada. Certainly, as we move forward, as the federal government has announced that it's one of its priorities is to legalize marijuana. And so, of course, there's many different models that they can follow, but certainly they should be learning from how we've addressed other kinds of products, whether it's tobacco, food, or anything else. So hopefully we are having this kind of learning, but noting that the context for the different products is so very that we can't just copy one model onto the other.
Great, thank you so much. And so I think we have officially had no more questions come through. I may have been a little too early to say that we didn't have any questions, but it looks like you've tackled all the questions that have come through, so thank you to you both. And now, Charlie, I will turn it over to you for the very last word, if that's okay.
I was just going to say thank you for everybody for coming, and thanks to Health Evidence again. I guess to give another shout out to Health Evidence, so thanks so much.
Well, thank you from Health Evidence, and So thank you all for joining, and we hope to see you again soon on another webinar or health evidence or maybe cross paths one day. So thank you, everyone, and have